Hello everyone, my name is Chadi Alraies from Detroit Medical Center. This is King Fahd Armed Forces Conference, specifically talking about structural heart intervention. I was asked by Dr. Al-Asnaq to comment on a couple of studies related to mitral valve surgery and intervention that was presented at TCT 2020. The study presented at TCT titled Outcome of Mitral Clip in Patient with Acute Mitral Regurgitation in MI with and without cardiogenic shock. This is a phenomenal trial that was done evaluating patients presenting with acute wide open myocardial mitral regurgitation in the setting of acute myocardial infarction. Again, it was very hard to recruit for this trial, obviously, because these patients developed acute rupture of tendon or because of dilated LV post myocardial infarction. Severe mitral regurgitation has been prevalent of almost in 50% of myocardial infarction due to mainly functional MR, and may account for 3% of MI and 10% of those presenting with cardiogenic shock. So there's a good cohort of patients who can present with mitral regurgitation in the setting of acute coronary syndrome with cardiogenic shock. So the aim of the trial was to assess the clinical and echocardiographic outcomes of cohort of patients with acute myocardial infarction treated with percutaneous mitral clip, and comparing those who developed cardiogenic shock to those performed in stable clinical settings. The primary objective was to acute procedural success, number one, and also clinical event, which is death, readmission, heart failure, and a redo clip or cardiac surgery. Secondary objective was MR grade and NYHA classification. So this is baseline characteristics of the patients. As you see, total patient was 93 patients involved in the trial. 50 of them were with cardiogenic shock and 43 were without cardiogenic shock. There was no difference in terms of characteristics except for the Euroscore of 2 was more prevalent, obviously, in the cardiogenic shock cohort. In terms of infarction location, the anterior was 35%, but the inferior obviously in 43%. And this is obvious for especially in patients who develop acute myocardial regurgitation in the setting of myocardial infarction. STEMI was 73%, is a very good percentage of patients. Multi-vessel was present in 78% of patients, and PCI was performed in 71% of these patients. Impella or ECMO was performed in 40 plus patients, which is indication for how sick these patients are. In Sky Shock, majority of them in Class C, 36.6% were in Class C. And also to elaborate on what is Class C, as we know from the publication, lactate more than or equal to 2, creatinine doubling more than 50%, and also increase in LFT, elevated BNP, and urine output less than 30 cc per hour. So again, this is very sick cohort of patients requiring a lot of mechanical support and requiring a lot of pressors. So again, as a reminder, 36.6% were in the Sky Shock Class C. In terms of echo, ejection fraction was in the cardiogenic shock cohort of 34% and 38% in the non-cardiogenic shock people. The days from the time of the patient was presented with acute coronary syndrome with and without shock to the time they received the mitral clip was 24 days in the shocked patients and 33 days in the non-shocked patients. Again, as we know, these patients are sick, they have pressors and mechanical circulatory support. By the time they are weaned off, they have a repeated echo confirming the nature of the mitral regurgitation, and then we're presented to the heart team to evaluate these patients for candidacy of the mitral clip intervention. You see the combination of XTR, which is the new generation, and NTR mitral clip was majority of these patients in 83% and 4% respectively. And procedural time was 143 in the shock patients minutes and 43%, so longer in the patient who are in cardiogenic shock. And I'm assuming this speaks to the fact that these patients are sicker and require more prolonged procedure due to their hemodynamic instability. The drop or the decrease in the systolic pulmonary arterial pressure, which is an indicator for filling pressures of the LV, was significant in both groups, in the shock and non-shock, where the p-value was significant as well. So immediate resolution of PA pressures. Clinical event at 30 days, again, all-cause mortality for the total of 6.3%, but the non-shock patient were 2.3% and shock patient were 10%. Again, as you know from the National Cardiogenic Shock Initiative that started by Dr. Bill O'Neill in Detroit area, the shock patients were almost 70% mortality, and now we're down to 50 in this registry. But now, as you see here, the shock mortality is 10% only. Clinical event at 3 months, again, all-cause mortality is 12 in the cardiogenic shock and 2.3% in the non-shock patient. Readmission, again, 13 and 23. More patients being readmitted in the non-shock patients. And I think this speaks to the fact that since there's more mortality in the shock patient, they are less likely to come back to the hospital, or probably they are getting treated at an acute care facility after discharge. Redo clip or surgery is 6 in the shock patient and 2.3 in the non-shock patient. Improvement in functional class also was in the shock, and there's no difference in terms of improvement between the two groups. One of the important also endpoint was endpoint is a heart failure rehospitalization at follow-up, because as we know, the mitral regurgitation is a significant contributor to the hemodynamics and also to the pulmonary edema and heart failure readmissions. So median follow-up is 7 months. All-cause mortality was 16 in the shock and 9.3 in the non-shock. For hospitalization was 28% and 25%. Again, almost 1/4 of these patients getting readmitted back in the hospital, even post mitral clip. So in conclusion, this is again a high-risk population. Percutaneous mitral valve repair with a mitral clip appear to be safe and effective as an alternative for correcting mitral regurgitation and improving patient clinical profile with acceptable rates. Shock, obviously, when adequately supported, does not seem to influence short and mid-term outcome, as we saw in these results. And the development in shock should not preclude percutaneous mitral valve repair in these patients. This is again a new option for these patients who are presenting with acute mitral regurgitation in the setting of acute coronary syndrome, with or without shock. These patients, maybe it's worth evaluating them for mitral clip before getting them discharged, or even after tuning them up and considering them for mitral clip. This is a very important study to kind of incorporate into our practice. But I would like to caution again that this study was done at a high volume center with a success rate of deployment of mitral clips is beyond 90%. So generalization of these findings cannot be kind of implemented in all centers. However, this is a call for re-evaluating these patients, especially who have or present with acute mitral regurgitation in the setting of acute coronary syndrome. Finally, I would like to thank the director of the course for inviting me for this small contribution to the conference. Hope you found it useful, and please be safe. This is Chadi Alraies from Detroit Medical Center.